Hi, this is Dr. Mary Grady, and I'm here to do a little vignette or presentation about client teaching or patient teaching. We use client and patient interchangeably, and there's times the Board of Nursing will go from it being part of what we need to say as a client, they'll go and change the verbiage to patient, but just either one is good. The goals that we're going to talk about in this presentation is how to address the knowledge deficit for our patients and promote or maintain the highest level of health that they have attainable. So we are an educator. It's an important role of the nurse, and it's one that's defined within the state nurse practice acts that say that we are a teacher. We are responsible as RNs to make sure that our patients and their families are educated on their health and the expectations of any ongoing or homegoing education. Nurse education is within our scope of practice, and it is very fundamental to what we do. The RN must also provide this health promotion and teaching by methods that are appropriate to the patient's developmental level, their learning needs, their readiness, and their ability to learn, their language preference, their culture, and their situation. Joint Commission, which makes all the rules for the hospitals, and they say that patient education is something that has to be done, and all patients must receive this specific to their needs and abilities. We do formal, we do informal, but we have to remember that what education does is it empowers our patients to become active in their own health care, and that is what we're after here. The RN role is our patients need to be informed about health, and it is our role to act on their behalf to try to get them what they need to know so that they can take care of themselves. Just so you know, as I go through this PowerPoint, you have this PowerPoint available to you as well in the Canvas site, so I'm not going to read every single thing on the page. Here's a little joke here that you can look at. I just want to remind you that the education process is compared to the nursing process, and the steps run very much parallel to one another. We have to assess our patients and get data to know what the knowledge level is, their desire or motivation to learn, their ability to learn. We have to plan by figuring out what goals there are. The patient needs to help us figure those out. Develop an individualized teaching plan with patient-centered goals and objectives. We implement it then by carrying out this teaching plan using instructional methods and tools. We then have evaluation where we determine if the goals were achieved, review the behavior changes or the outcomes, and see if we actually have what we want to have happen. Don't forget, I've said it before, I'll say it again. Education is used to empower the patient and is an important aspect of quality improvement that helps with better health outcomes. Consumers trust RNs to be their advocate and to rely on them to assist in achieving these. So we have a lot of responsibility here. Patients, they look to us to help them get better lifestyles. The need for instruction, we also have to remember that there's a lot of DRGs and there's a lot of regulations going on that people don't stay in the hospital very long. So we need to teach them how to care for themselves outside the home. Just to remind you again, the registered nurse, it's our job to keep people healthy and to promote health and to educate them. Nurses who fail to provide proper patient or client education not only increase their risk of civil liability, but also, and more importantly, are negligent in their nursing practice. Especially since our patients aren't staying in the hospital very long, we have to give them the tools that they need to take care of themselves. So what are some principles of this learning? We need to establish trust with our patient, partner with them, take into account their different learning styles, individualize. Just don't pull something out of a box and say, I'm going to teach this, but make it work for that person. What is that person's strengths so that I can capitalize on that? What is their developmental level? what is what I want to, the behaviors I want, and the new learning experiences I want to enforce, and what is the language they need. I need to also know that repetition also helps with learning. I want to teach and I want to counsel. I want to be there to assess the patient's health and well-being and how I can help them to learn what they need to learn. I want the patient to know that they can trust me. I can't be distracted by other obligations when I'm teaching. I have to give my active listening. I have to be mindful in the moment and let that person know that they're important. And I also, when I'm teaching, have to keep my explanations clear and understandable and no medical words. I think I've told people before, I had a patient once that didn't know what a bowel movement was, but they knew what poop was. They didn't know urination, but they knew what pee was. I have to make my jargon and the words that I use be explainable so that that person knows what I'm talking about. We need to use health promotion and health teaching methods. They need to be appropriate to the situation. Like I said before, the developmental level of my patient, addressing their learning needs and their readiness and their ability to learn. Sometimes we have to jump in before the person is ready. Example of this might be ostomies. You used to could come in, get your ostomy done, and be there for a week so that you had plenty of time to adjust to the fact I have this ostomy and to be open to teaching. And now we're pretty much having to do a lot of this while a person's not feeling good or hasn't reached that point. But for the best part is to assess their readiness, language preference, and the needs of the culture. Most of the people we're working with are adult learners. And even if we're working in peds, we are still working with parents who are adult learners. And we have to remember that adults, whether they be our patients or our parents and family members, they come to us with a lot of information already that they have learned through life. And their experiences influence how they're going to perceive our formal or informal learning situations. So we need to keep that in mind as well. Individuals can choose to learn or not to learn. Getting a person to buy into why something's important is really a big part of education. I can tell someone they need to quit smoking, but until a person really recognizes that that's important or it's tied to their condition, it may not happen. Just remember, more information is sometimes better than less. And multiple methods to get that information to a person is very important. And as you will see later on our teaching plans, we have you thinking outside the box, like trying to address the cognitive, the psychomotor, and the affective domains of learning, so that hopefully that this likelihood that your patient will retain the information better because you're hitting different domains of learning. Teaching is more than a transmission of information. Information needs to be received and understood and evaluated by the learner so that you know that it actually did occur. Learning is said to have occurred when you get the outcome that you want, the behavior you want, the positive outcome. There are different domains of learning, which I mentioned before. There's three big ones: cognitive, affective, and psychomotor. And the more you involve these three domains, the better your outcomes are going to be. Cognitive is knowledge. It's thought process, person's intellectual ability. Cognitive is usually like for a nursing student, is your lecture portion of the class. What you're doing right now is a cognitive activity, listening to this lecture. Affective is your attitude and behavior that you demonstrate. It's your feelings. It's your values. You value the feel of nursing, and that is why you're working to go into this. I didn't have to do anything to influence that. You came already with that in place. Psychomotor is demonstration. That's where skills like lab and clinical come into play. when you're starting to look at these things, to write your teaching plans, just remember there's something called Bloom's. And Bloom's has different levels and different verbiage that you can use when you're trying to write these teaching plans. Verbs, you need action verbs. So just so you know, knowledge is less like a if you want someone to do these type of verbs, this is not as high functioning as comprehension or application or analysis, synthesis, and evaluation. So you choose the verbiage you want to do. If I look at these words here, I think of the word cognitive. Some verbiage from here that might be cognitive would be have someone to define, to have someone to name, someone to reproduce or state, someone to repeat, someone to state is a big one, or restate, explain, discuss, describe. Those are adjectives that you could use in a cognitive setting. The other one that you had was psychomotor. Those is demonstrate, perform. You might have someone list. That would be psychomotor if you have to write it down. Some people think that's cognitive. Some of these might kind of leap over into different categories. Practice. Writing is a cognitive skill, a psychomotor skill, I mean. Demonstrating. If you were to have something with the affective, which was that domain that we talked about with the touchy-feely and valuing, some of the words that you can use for that would be value. You might want them to explore. You might want them to express. Those are the kind of words that you would use in that particular case. And then over here you've got some different verbiage here that you could, like just verbs that you could use, and you could figure out where they would fit in which 3 domains of learning. So this is just giving you a little bit of extra to work with when you go to write those teaching plans. It helps a little. And then, like I said, this kind of explains some of the verbiage and the different levels. Now there's also something on your teaching plan sheet that you've probably seen, and it talks about barriers to learning. Excuse me, I knew I was going to do that in the middle of taping, sneezing or coughing or something like that. But anyway, excuse me. So barriers to learning. Just so you know, mild anxiety enhances learning, but moderate to severe distracts from the learning process. So when you are mildly upset or anxious on the day of your test, that's good, your brain's working. But if you go past that mild into that moderate and severe, that's where the learning starts to break down. You have this thing in your brain called the amygdala. And when you get upset, the amygdala kind of shuts things down, and information cannot get to the frontal lobe. And the frontal lobe is that part where you really need it because it helps you kind of process information. So the best thing people can do when they're anxious is take a deep breath, because when oxygen gets to the brain, the amygdala starts to calm down. So that's just a little FYI. I have to assess your readiness to learn, your physical ability to learn, your psychosocial situation, and your prognosis. I had someone once psychosocially, they were homeless. So they couldn't focus on learning anything because they were too busy trying to figure out where they were going to live. The learning environment where I do my teaching, I have to think about that. Is it in a room where there's not going to be a lot of distractions? The room is comfortable. The patient has a comfortable place to sit. I'm also going to look at like any problems that they may have with attention span or effects of meds. Maybe if they've just had medication like for pain, maybe that's not the best time to do my teaching, because not only are they hurting, but their medication might make them sleepy, things of that nature. I have to be creative and keep all that in mind so that I get the best bang for my buck when I go to teach. Just know all 3 domains need to be done, especially on your teaching plans. So with all of that said, the first thing we have to look at is writing a nursing diagnosis. You have to assess and diagnose what are the needs. Well, if it's a teaching plan, here's a tip. It's probably going to be a knowledge deficit. It's probably going to be ineffective health management or noncompliance, any of those. So then I got to write the nursing diagnosis. If it's an actual problem, let's say knowledge deficit, it needs to have 3 parts. It needs to have the nursing diagnosis. It needs to follow that with related to, as evidenced by. So you have a diagnosis, related to, and as evidenced by. That makes it an actual problem. So a knowledge deficit related to patient having to use the AccuCheck machine at home, as evidenced by patient saying, I've never seen a machine like that before. I have all 3 parts. You can have a risk problem. Let's say you have a risk for a knowledge deficit because the patient has been prescribed new meds or a new procedure to do at home, but the patient, as evidenced by, they understand it. You're at risk for it because it's new and they could have some issues in that regard, but they don't have anything to evidence by that this is a problem. So a risk as opposed to an actual problem has the nursing diagnosis and related to. You have no as evidenced by because there's not a problem yet. You could have a risk for falls related to leg cast, but until they've actually shown you signs and symptoms that they are as evidenced by that this is an actual problem, it remains a risk. So then I have to plan. I've assessed, now I plan. I develop my patient or my client outcomes. Who does what, when, and where. So maybe I have Mrs. Jones administers her insulin in the abdomen in the AM and monitors her blood glucose prior to discharge. I probably want to be even more specific than that. I probably want to go on to say Mrs. Jones administers her insulin in the abdomen in the AM times 3 days, successfully for 3 days. I want my outcomes to be very timely, and I want them to be something that's measurable. I could even say she administers her insulin in the abdomen in the AM this AM, or I could say this AM, so it makes it more specific. I could say Mrs. Jones monitors her blood glucose prior to discharge. Or I could be even more specific. Mrs. Jones will monitor her blood glucose every AM prior to her discharge. So it's very timely. It's very manageable. I can tell whether the person has actually done it or not. I'm going to use demonstration and return demo for a lot of things. Teach back. That's probably something you've read about in your book. Teach back. If not, just kind of Google it and look at it. A patient is observed completing a task. They have no problems, and that's good. You watch for the effectiveness. A return demonstration of a procedure once does not mean the patient has achieved understanding. You may need to go back and have them do it like on a different date as well. Don't coach the patient through the procedure and document what they understand. You're watching them, kind of like a lab checkoff where you're watching to see if that patient can do that if you're not there. So that's very important. Include significant others and family because we are not by ourselves. With family-centered care is very important. The family can assist in the learning process and they can reinforce the teaching as well. And this is very important to keep in mind. You use technology. Technology is very important. Clients and technology. Find things online from sites that are like .gov, things, not WebMD or Wikipedia, but things that are things you can use. Also, a lot of hospital systems now have their own teaching methods that they have online that a patient can watch or they can watch at home. Provide written instruction But remember, not all people are going to be able to read. And sometimes they'll take things and tell you they can read, but they really can't. So you need to follow up on written material. Also with your teaching interventions in that section, what are you going to do with that? Once you've wrote your nursing diagnosis, actual or risk, and you've wrote your learning outcome to be timely and measurable, it's going to ask on your teaching plan what your interventions are. You might use lecture and discussion, you might use demo, teach back, role playing, value clarification, but you're going to do something that shows that this is how you're teaching the person. Other strategies I have listed here that you could possibly use. And then you want to seek opportunities for feedback and evaluation to see if the strategies that you used are actually working. So when you go to talk to a person and evaluate, you're able to tell if that person is able to complete your learning outcome. So if Mrs. Jones was able to give her do her AccuCheck every morning successfully before discharge, I could then say in my evaluation that Mrs. Jones was able to do, and so she met her qualifications. Or Mrs. Jones was only able to perform it on the last day, so it was partially met. But I have to evaluate to make sure that I'm actually doing the things I'm supposed to. Was the outcome criteria relevant, measurable, and did the client, were they able to perform it? So ways to evaluate is with return demonstration. You could even give a person, ask them some questions, give them a little questionnaire to ask questions with, talk with family members, get their opinions of how things are going with themselves and the patient. You're going to assess things like weight, blood pressure to see whether the patient was able to follow a modified diet plan, if that was something, or exercise program. So there's other ways that things are evaluated when you teach and then they come back for a repeat evaluation through their physician. Review if they've done their blood sugars daily. They tell you they have. You'll be able to evaluate that in a doctor's office once they come back. Evaluation is ongoing. They'll be able to look at that and say, okay, they were taught this. What does their A1C look like? What does the patient look like? We need to document everything. If something is not documented, it is not done. And it's an important part of evaluation that I taught you, and then I evaluated that you knew what was going on. Like maybe you were able to identify 5 signs and symptoms of hyperglycemia before discharge. That is something that I can put down as my goal, and I can measure that and say that you actually did it. Please note that a lot of insurance companies are getting kind of picky on their policy for reimbursement requirements. So hospitals are going to have to bump up their patient teaching if they are expected to get reimbursement for that. Charting mistakes to avoid. I just put a few here just as a little FYI. Failing to do any of these things could result in the hospital not getting their reimbursement for the care that you have done for that patient. The teaching plan that you're about to write, just to recap it, you're going to start with a nursing diagnosis or the reason why you're teaching. I am teaching you because you do not understand that medication. You have a knowledge deficit related to insulin, as evidenced by you've never taken it before and did not know what it was. So that is something. Why? Asking yourself all these questions to come up with that. When you write the nursing diagnosis, there we go again, related to, I don't even know why I'm taking this. If you don't have an as evidenced by to add, then it's a risk. Risk for knowledge deficit related to medications the patient is currently taking. If I don't have anything to put as evidence by, then it becomes a risk. Client learning outcomes, you're going to address the cognitive, the affective, and the psychomotor. You have to have at least 3, and they have to have 1 from each of these categories. Cognitively, they will state information. That's a verb that I said before that kind of shows cognitive skills. And it's very timely by the end of the clinical day. Affective, they will value the importance of taking their meds on time by the end of the clinical day. Or they will demonstrate the proper way to self-medicate by the end of the clinical day. Those are all timely and measurable. I'm going to have my teaching strategies next to my outcome. So if I am teaching them like signs and symptoms of hypoglycemia, I may have done this with a video and a brochure or maybe a lecture. Then the means for evaluating is going back to that learning outcome and look at that. My criteria is the patient will verbally state 1 reason for the medication and 2 side effects. It's very specific, and then I'm able to say the client did it as my evaluation, whether it was met or whether it was not met. There's also a little section on there about learning barriers to think about. Maybe like in the case of this, the patient was post-op and on a morphine PCA pump. I didn't have a better time to do it. We had to do it right then to get it started. Maybe that was a barrier and someone knows to kind of follow up on that and to try to help do it again. And then the outline portion. The outline portion is at the very back of your teaching plan. It's a separate sheet, and I call that the sub-plan. That is the plan that if I am not there for the day and someone picks up my information, they should be able to follow it. It is the content that says if I wanted them to learn the signs and symptoms of hypoglycemia, I list them there so the person teaching knows what that is. If I want the person to know signs and symptoms of infection to watch for at their wound, I'm going to have them listed there. At the bottom of all of these, it is going to ask for a reference, a scholarly reference of where you got this information from. It can be your textbook, it could be the .gov site, it could be the Cleveland Clinic site if you're doing something in their facility like a cardiac cath, for example. But I need to give information, show where I've got it. So that concludes our little program here. 27 minutes worth of this on client teaching or patient teaching. So I'll be making more of these. Bye. Take care.